This conference will now be recorded.
Okay. Well, hello, everybody. Right now, we've got a nice small group, but you never know what's going to happen. But maybe we'll get to talk casually about a lot of different things today, which would be very nice. One thing I did want to do before we get into our own issues is just to let you know that our partners at Us Too are holding what looks like a pretty good conference next Saturday. I mentioned it briefly last time speaking with Les. The conference, everything's free. The conference is in Chicago Loop, but it is being webcast. Although they ask you to sign up ahead of time, I'm not sure how essential that is. They've got some pretty good speakers, certainly some people that we like. Some of you may have already seen the flyers, but if you haven't, it includes Alicia Morgans and Maha Hussein, both of them. And then they've got they've got a surgeon who I'm not familiar with, called Kundu, a genetics person. They've got a men's sexual health person speaking, a radiation oncologist, and another oncologist who I'm not familiar with, David Vanderweel. They're all on staff at the Lurie Cancer Center, which is affiliated with Northwestern. So the conference is on the 9th, a week from Saturday. And I am certainly going to try and listen in because I would like to hear both Maha Hussein and Alicia Morgans, and there will be opportunity to ask questions through the webcast. So I don't know, I haven't seen a more detailed program, but the conference goes Central Time from 10 o'clock to 3 o'clock. So it's only 5 hours and there's a lunch in there. So it's probably only 4 hours of speakers. So I don't know more. I may try and get hold. If I do get hold of a program, I will add it to our website where we've put an event posting. And
I added the link for if anybody wants to register in the chat box.
Okay, yeah. Thanks, Jake. Jake's put the link in. I was going to put our event link in it, but Jake's put their event link in, which is just fine. So so there's a link there, and if you're on the telephone, if you go to our ANCAN website and look under events, you'll see it posted there as well. Okay, and anybody want to say anything about the Us Two conference? Okay. So let me run down the list and let's see how we're going to schedule out the time today. Jake, anything you'd like to tell us?
I have a semi update.
Okay. Okay. Carl, anything you'd like to talk about?
Yes.
Okay. Les, anything you'd like to talk about?
Yes, just briefly.
Good. Okay. And I have a question for you too, Les. So when we come to you. Paul Frieda, anything for you tonight?
Nothing for me tonight, thanks.
Okay. Leonardo, anything you'd like to talk about? See?
Yeah,
okay.
as you know, Rick, I have a probably a 10-second PSA update. You can put me at the end.
No, we're not putting you at the end because you never know what 10 seconds can lead to around here.
It's true.
Sylvester, anything you'd like to talk about tonight?
No, thank you.
Okay. Ken Carlson, you do have an update for us, a long update.
Yeah, I do, and a couple of hopefully focused questions for you.
Okay. Ken Anderson, anything you'd like to discuss? Mr. Anderson.
I know I'm on the phone, but I'm here. I mean, I don't really have anything. I could give you a little update on enzalutamide and how I'm feeling.
Okay, that'll do. We'll take it.
Okay.
And Peter, anything you'd like to talk about?
I think I brought this subject up a couple of weeks ago, but I wouldn't mind talking about it a little more honestly. Yeah, just the ethics of ADT.
Okay. Yeah, that's always a good one to talk about. All right. Well, let's since we haven't heard from you for so long. In fact, let me see when the last update was that I had for you, Mr. Carlson. And I'll let me see here. Carlson, Carlson. The last time that I have a note about you was that you started ADT in August of 2017. Does that mean we haven't spoken to you for 2 years?
Or else I may have dialed in, but just not, said anything. But probably that's probably accurate.
Okay. Well, since the last we know that back there in Sacramento, you started ADT in the summer of 2017. Why don't you fill the guys in a little bit on your background so some of these guys don't know you, and bring us up to date, please.
Okay. Let's see. 2010 diagnosed, biopsy, 4+3 multiple cores. Lupron started January 2011 for 6 months, I think. IMRT, I think it was using that that transponder thing they put in you for 2 months. PSA was okay. Then I think in 2015 it started going up, and then it kept going up. And then I guess the doctor I saw, he probably wasn't the wisest choice. He felt that it could go like to 3 or 4, something like that. So in any case, I started Lupron in 2017, as Rick mentioned, and that was, okay, or at least the tracking of, it took a while to get down. And then I guess I had read about, intermittent, and I also read how controversial it was because the Axeman scan that I had right before the ADT showed that it had spread. Most, it didn't mention bones. It definitely lymph nodes all over the place. So anyway, I did it anyway, probably not knowing, what I should have done or not. And about a year later, I think, so that was about a year, 2018, the year of 2018. Then it started going back up. And then in the meantime, my wife a year ago developed very serious peritoneal cancer, and suddenly everything was, upside down and chemo, and I became, the caregiver and sort of ignoring myself a little bit. So the PSA, or ignoring myself a lot, I should say, PSA got higher, then started the ADT again, found a doctor that was better than the one that I had, or at least more personable in any case. So in June of this year, started ADT again. 2.5 months later, the first PSA test showed that it had come down to 1.0, and the testosterone has been, less than 3, all that, from that time to this time. So, doctor and I were thinking, okay, I'm going to have another run of, using Lupron only. I think we had discussed, well, what about using second line with it? And I guess he had talked about pros and cons, and that I wasn't, what I guess he called high risk. So we're going to go with, the ADT. And I'm hoping for, time on that. But then the PSA test 3 weeks ago that I finally looked at yesterday, because I tend to hide in the sand, showed it at 2.2. So I knew that even before talking to him today, that we were at the castrate resistance, milestone, and spoke to him today, had a long conversation, and he agreed. He thought, going up that much was not just a fluke or an anomaly. And we started talking about Zytiga or Xtandi, which now I'm leading to my, question. One of my questions I want to ask. He felt that based on recent studies that he was seeing, I'm trying to remember, that he was seen in the metastatic castrate resistance, and I forgot to add that my Axeman of earlier this year showed spread to the bone as well. I know Axeman isn't perfect for that, but that's what we've got here. Anyway, he said that in recent studies he's seen, and he didn't always believe this or feel this way, that he felt Xtandi could be as helpful as Zytiga in the, I guess, metastatic castrate-resistant space based on that, whereas in the recent past he has always advocated for Zytiga plus prednisone. So he mentioned that, and he knew I was concerned about prednisone. I guess I'm like so many people, you look up prednisone without understanding that as he explained, the Zytiga prednisone is a lower dose and absolutely needed versus the high dose. And, you start reading this stuff and it's like, wow. I mean, I was just, my tears compounded last night, first the CR and then that stuff. So anyway, he said, go think about it, talk to people, read about it. Of course, investigate the prescription assistance programs for each. So I guess my question just about that is, for y'all, what are y'all's thoughts on that? Do any of you take one or the other? And then he was talking about, sometimes people can switch, but sometimes if they switch, it's not as effective. We were talking about a lot of stuff in a short amount of time because I had to go have the ADT shot after that. So that's, one of my questions. And I guess another question is, I'm feeling pretty good. I try to exercise and do the weights, but I've got, my energy is for my wife. How much of a hit am I going to take with either Zytiga, Xtandi, on top of, the ADT? So I better stop at those two questions because I got a few more, but, that's more than enough to ask at this point. So I'm, confusing. Of course, I've read these things, but yet I never really paid attention. And now that I'm in that bucket, okay, fine. Anyway, I'll stop.
So there's a lot of knowledge on this call as usual, Ken, both with starting these drugs, with intermittent hormone therapy and the choice of second-line anti-androgens to go with them. So right off the top, there are 3 people I want to visit with, who are Len and Ken Anderson and Peter. And then in the interim, there's something I want to look for along the way that I just read to see if I can find it. So I'll slip that in along the way. But our stars of intermittent have been Len and Peter. So Len, why don't you pass on your experience to?
Well, I think I just want to make one comment. For the intermittent, I mean that's in the past. Whether it was right or wrong, that's in the past. And I realize that's not going to ever happen again. So I don't know. I'm not, really asking.
Why do you say that? Why don't you let Len and Peter talk to you? Okay.
Okay. I guess my assumption was that once one is castrate resistant, then that's not a world to live in anymore.
Len.
I have no knowledge. It's just some emotional assumption. I don't know. Anyway, Len, Peter, go ahead. I apologize for it.
Len, you start.
Len? Okay. So, hi, Ken. I'm not sure we've ever spoken before. Where to start? Well, okay, let's start with the intermittent. I recently became metastatic to several bone lesions. And I, like you, I thought, well, I guess that's the end of my intermittent ADT career. Before I've had two successful runs with ADT. One went as far as 30 months. But my oncologist said, no, not necessarily. It depends how you respond to the second line ADT regimen that I'm on right now. So it may not be the end of intermittent for you, who knows? But we'll put that aside. I think your more pressing question is Xtandi versus Zytiga. To my knowledge, there's no superior, neither drug has superior efficacy to the other. Although, of course, they've never been compared head to head. Now, I just posted in our blog a study that went on for 12 months and asked patient preferences for those who were on Xtandi and those who were on Zytiga. Sorry, and the preference seemed to be Zytiga over Xtandi with regard to side effects only, not efficacy. But Zytiga appeared to have less cognitive fog and less fatigue than Xtandi.
Okay.
But again, this is strictly speaking, side effects. Efficacy was not measured. As long as you have no cardiovascular issues and you're not diabetic, I wouldn't worry about the small dose of prednisone that you're taking, that you would be taking with Zytiga. It's basically just a replacement of the cortisol in your system that you're going to lose if you go on Zytiga, because in addition to testosterone, Zytiga blocks production of cortisol.
Okay.
And
okay.
so I guess I can. Well, one other thing I'll add, I'm on darolutamide now, is a newly approved second line anti-androgen, similar to Xtandi and apalutamide. And I'm finding, for me personally, that there's no cognitive deficit and less physical fatigue compared to Zytiga. I've never been on Xtandi, but I have been on Zytiga. So that's my personal experience. As long you said you were positive for bone mets on Axumin.
Yeah, it showed some spread.
Finish right here before I forget. So if you've had a technetium 99M bone scan and that was negative, you would still be considered eligible for darolutamide, which is normally only approved for non-metastatic.
Oh, okay. So darolutamide is not metastatic. Okay. Are you
with technetium scan?
Okay. Okay. So they still use the 99 scan since even though it's older than the one that they stopped paying for, the F18.
Believe it or not, it's still considered standard of care.
Okay.
So let's just clarify that, because this is really, really, really important. So the definition of non-metastatic for drugs like apalutamide and darolutamide are referring to scans that have been done with old equipment, and if you show as if you have no bone mets on that, even though an Axumin or a PSMA scan shows bone mets, you would be considered non-metastatic and you would be eligible for apalutamide or darolutamide. Now, darolutamide from, and Len maybe will talk about this a little bit more when we come back to him on his PSA update, but darolutamide appears to be, to have a distinct advantage over all the other second-line anti-androgens because it does not cross the brain barrier, so it doesn't impact the androgen receptors that are in your brain. And because of that, it doesn't cause some of the fatigue and cognitive issues that the other drugs seem to result in. So I just want to make that really, really clear. It is so important. I mean, it may mean that for somebody like Ken Carlson, you've got to go back to your doc and explain this to him and say, Doc, I just want to do a regular old bone scan and see if my mets show up. Because if my mets show up, it don't show up, then I might be able to get darolutamide.
Okay, is that a branded product, just like Zytiga and Xtandi?
Yeah, it's called Nubeqa.
Nubeqa,
Trade
okay.
name Nubeqa. Nubeqa.
Okay, yeah, I'll definitely look that up. Yeah, is it something that's had a number of studies, or not, I guess not as much as Zytiga or Xtandi yet?
Not as much because it was only approved, I don't know, 3-4 months ago.
Okay, okay. All right. Definitely I will look it up for sure.
But Rick, one thing I want to say, I believe that apalutamide has now been approved for both metastatic and non-metastatic.
Okay.
And eventually, I'm sure darolutamide will be approved. You know, they're probably running trials right now, but it's a newer drug, so they haven't got results yet.
Okay, let's go to Ken Anderson and then to Peter, because Ken, you just started enzalutamide, right? Having only been on Lupron and bicalutamide before that.
Yeah, I'm not sure, Rick, how much I can add to Lynn's kind of information. I would have loved to have been able to get, darolutamide over enzalutamide, but, I've bone mets, so it's not possible. I was going to put in a request to Paul to see if there's any way he could, I don't know, push my insurance company a little bit, but I've been handling enzalutamide fairly well. I do notice a little more fatigue. As far as being mental, I'm freaking mental all the time anyway, so it doesn't really matter. I can sympathize with you in regards to the stress starting, the next drug. I mean, I waited 7 months prior to Lupron failed about 7 months ago, and every month I watched my PSA go up and said, hey, I should start, and I just didn't. So I went from like 0.7 to 4.2, 4.45. And even when I started, it was a pretty difficult, I guess I had the pill bottle for 3 months. No, I'm sorry, 30 days before I actually started taking it, primarily because everyone said, yeah, you have to. So, and after I got my last PSA, it's just a require. You have to move along to the next drug, and you just got to get your arms around it and say it is what it is.
Right. What led you to Xtandi versus, say, Zytiga?
Well, just prior to, prior to my going, castrate resistant, I decided to do Provenge. And I had a discussion about doing Provenge as well as what my next drug might be with my medical oncologist at MD Anderson. and he advised me the best choice for me if I wanted to do Provenge once I go castrate resistant would probably be, enzalutamide, because there's something about, taking prednisone that affects or blocks your immune system or something, and then probably could add to whatever that is. But the fact is it was his recommendation that would be my next drug, primarily because the prednisone suppresses your immune system a little bit, and I just went through a fairly extensive, three sessions of this Dendron's drug, Cipatel C. So that's the reason I chose it.
Okay.
I probably would have not chosen it had I not just finished Provenge, because everything I read
Right.
today states fatigue is much less, doing abiraterone, fatigue and mental fog, but by all means, as Lynn suggested, if you can get on darolutamide, I would really work hard at it,
Okay.
But I just bite the bullet, and it's just something you got to do. And I know Rick pushed, and I kind of held off as long as I could. I figured 3, and I went above 3, like 2 months above 3. So.
Well, if you had took 7 months and you was only up to 4 point, that was a good sign in that it was going up much slower than I see mine going up.
Yeah, I calculated on the Sloan Kettler, doubling time with the past 7 months, and my calculation with their whatever that's called is 3.2 months. So the doubling time was 3.2 months. So,
right.
But yeah, I wish you luck and stick around because, yep.
Yeah. Okay. Well, thank you. This is good and interesting data for sure.
Ken, I know it's difficult. We had this discussion last week. It's difficult to actually measure the size of the bone mets, but do you have any idea how large the bone mets are, and where did you say they have been seen?
Well, you already know, Rick. You can't measure the little buggers.
No, but I'd like to know what Ken Carlson's doc said to him about the bone mets.
Oh, you're talking to the other Ken, not me. Gotcha.
Yes, sorry.
Let me get my eczema report and see if I can find that. It talks about all sorts of the lymph node, muscular. There is interval development of multiple hypermetabolic foci within the image. Osseous structures very suspicious for metastatic disease. Some of the reference lesions include superior aspect of the right scapula, left aspect of the sternum, left aspect of TA, right posterior acidibulum, and proximal left femur. Several of these lesions appear to correspond in locations to areas of subtle sclerosis on the low-dose non-contrast CT images, while others do not appear to have definite anatomic correlates. So that's all it says. The rest of it is about the, lymph nodes all over the place.
Okay. Well, it's fairly vague, so you may be in with a shot with this technium, this old technium technology.
Yeah, well, I will bring up to my doctor, about that. He even though he's a general oncologist, he's really sharp and seems to keep up with lots of stuff and studies, and has a lot of patients, prostate cancer patients that he's following. So I will bring that up and read about it myself as well.
Peter, I know you have some thoughts on this issue.
Yeah. So some of my comments are going to be peppered with some personal opinions that I'm kind of working through. That probably have no scientific validity, but I've got some strong opinions. Anyway, I've been on intermittent ADT for 5.5 years. I started out on ADT. That was my first treatment before I had any surgery or radiation. I was diagnosed as a Gleason 9, symptomatic, on a catheter for 8 months or whatever. Anyway, so I've been through it. My oncologist is down at prostate oncology specialist down in Marina Del Rey, Dr. Turner. He wanted to put me on Zytiga pretty early on, actually, and I didn't want to do it, so I just stuck with Lupron and bicalutamide originally. So I've been on and off of that. This past year, though, all of 2018, I was on Zytiga, and this is my third cycle of getting off of all ADT drugs. I've been off since New Year's Day, January 1st. Actually, it took 2 or 3 months for the Lupron to get out of my system, but within 4 months, my testosterone started coming back. So I've cycled through this thing, this ADT trip, three times, and each time my testosterone did come back. Right now, I'm feeling pretty strong. I just came back from the gym, second day in a row. You know, I'm pretty active. My personal
Peter,
feeling is, yeah.
I just wanted to clarify. So I think you're saying at some point you were on Zytiga plus ADT plus prednisone, and during that time there was a time that you went intermittent as well, not just intermittent from ADT, but intermittent from ADT and Zytiga.
Yes, on January 1st, I stopped everything.
Okay.
So
Okay.
for the last almost 8 months, I've been totally off of everything. My testosterone came back and so forth. I'm a Gleason 9. At last check, I'm still hormone sensitive, so I have not developed intolerance to Lupron and so forth. I don't, at last check, I do not have bone mets. I did have some metastatic spread to my lymph nodes in my abdomen and had them radiated last November. But I'm a Gleason 9, so the cat was already out of the bag when I was diagnosed. I had surgery. I had my seminal vesicles removed and so forth. So I know things are on the move. And right now I've got, I check my PSA every 6 weeks, and I've got creep going on. So I suspect sometime in the new year I'll have to start something again. And I'm really suspicious. I so-called tolerated Zytiga very well. I mean, I was able to keep my exercise regimen up. It didn't totally wipe me out. I mean, I did feel it. Unlike some guys, I didn't have night sweats and heavy duty reaction in terms of that kind of reaction. However, I definitely noticed right out of the starting gate that Zytiga did a number on my head, and to this day it still affects me. I mean, memory things just went out the window, and it bothers me to this day. And I wrestle with this. I think, are we guinea pigs? I go back to that movie about the the guy who came up with the way to decode the Nazis during World War II, and they put him on androgen deprivation because they thought he was gay, and he finally took his life. I mean, these drugs are not to be messed around with and played around with, because they mess us up and screw us up. And I think that there's too much over prescription of ADT drugs. I think there's too much dependence on them. They're not a cure. They do suppress. They do keep our life moving a little bit longer. But my God, the effects they have are game changers. We all know this as men. I've been on bicalutamide several times. All these things just mess you around. Yeah. So I'm nervous. I'm nervous about, my doctor says go back on Zytiga. I think I'm going to balk at it. When I was at the PCRI conference in September, I talked to the people at Bayer about darolutamide, and they were saying that your doctor, you could get your doctor to get you, any doctor, if they ask for it, can get a 2-month supply free of darolutamide. But whether your insurance company will pay after that is a big question. But you might be able to try it for 2 months and see if it makes a difference in how you tolerate darolutamide for 2 months. And then if you have to go on something else, you can go on something else. But the advantage of darolutamide, they say, is that it doesn't break the blood-brain barrier, and it doesn't screw around with your memory. So
Okay, yeah,
that's a thought.
my question is, in the castrate resistance space, though, it's like there has to be something else rather than, when one's still sensitive, there might be, just ADT, but in the castrate resistance space, isn't by implication that it's one of these second line medications that are needed because the ADT isn't working anymore?
Well, they're going to put you on Lupron anyway. You'll always be on Lupron. I mean,
Right.
But they'll put you on. But darolutamide is a second line anti-androgen, and you can get that for a couple of months. Your doctor can ask for it, and then you can fight with your insurance company and see if you can stay on it. I mean, that's one way of going at it. I don't know what to say. I mean, I'm kind of going to be in that situation once again. It'll be my next round, and it'll be sometime after the first of the year, I'm guessing. But I did not like the way Zytiga messed up my head.
I guess it's,
I don't know what's any better. I don't know what's any better, and I'm hoping to hell that they start coming out with drugs that don't screw around with our mental capacity this way, because I mean that freaks me out. I mean, what would you rather do? Die of prostate cancer or become a vegetable where someone's answering all the questions for you and you're parked in front of a TV set, unable to remember your grandchildren's names? I mean, I don't want to go to that place. And I know these drugs seem to have an indication that they're pushing me toward that. And I could say, well, how do you know for sure? Maybe it's your age. I'm only 72, but I noticed a big difference last year. It just right out of the gate. Certain names, places, things that I always knew were just gone, and I had to sit there and count to 10 and go through the alphabet and try to remember stuff that I had right at the tip of my fingers, the day before. So that's my opinion. I think there's a lot of room for new drugs, and I'm hoping they're coming along that don't have this effect. And I think, if darolutamide's one, then maybe there's more coming along that will have different criteria and allow us to take it. So that's my story. I think there's something strong to be said for intermittent, to be able to have your testosterone come back, to feel strong, to feel a little bit like a human being again, and not just kind of drag your butt around all the campus all day long, and force yourself to go to the gym, and and everybody think you're just an old man over the hill. I think intermittent therapy is the way to go, and I'd keep doing it as long as I can.
Yeah, I guess as my doctor pointed out today, very kindly, the first step is to see if the ADT plus whatever second line is going to work, So he said, don't get ahead of yourself now, we want it to. So I guess that'll be the first step. And I guess I've got to find out if one has to switch. He said there's something, if you're on it for some time, there may be something, a cross resistance or something. I can't remember the terms that might not make the second one effective, whichever second one you choose versus the first one. So I guess that's the thing, with more choices, there's more analysis, like what I'm going through, the enzalutamide versus the Zytiga versus now the other ones. So yeah, thanks for your feedback on that, both the your experience and the IADT situation as well.
Ken, there's a lot more things we'd like to explore with you. You asked about cost, and we can certainly help you with that, but come back next week. Keep talking to us. Don't make it another 2 years. We've got to move along right now. We may cover some of the issues.
Oh yeah, no. Thank you. No, I appreciate it. Yeah, definitely. I'll come back. I guess there's more impetus for me now because I'm, in that castrate resistance, and I guess to me that was the thing that dreading for so many years, and here we are. So yeah, I will do that, Rick, and thank you and everyone for letting me speak.
Just before we leave you, how's your wife doing?
Well, she's doing okay. She had like 6 months of strong chemo, and she got sensitive to it, and now she's on Lynparza, a PARP inhibitor, oral medication, and she's doing. Her labs are okay. Their equivalent of PSA is called the CA-125, and
Right.
it's sort of okay. The doctor monitors it, and she's wiped out from both the chemo. I mean, she's in her 80s and wiped out, I guess, to some extent from Lynparza, but it's key that I do my caregiving thing and really do, I'm the patient advocate, the shopper, the cleaner, the whole 9 yards of it, and that's what's important to me at this point in my life, is to live long enough to be able to keep doing that with some energy, just like I've got right now.
How old are you?
Say it again?
How old are you?
Oh, I'm 72.
72. So keep listening, because one of the guys that's going to talk tonight is also on Lynparza. So
Okay.
So because we have guys that are on Lynparza as well here. Okay.
Wow.
Jake, tell us what's on your mind.
Okay. Well, I have a semi update. I had my visit with my oncologist last week. Had blood tests, of course, but I didn't get the results yet. She was talking about if abiraterone doesn't work, she was thinking about apalutamide for me. But anyway, I called today and I didn't get the number, but because I needed to know, do I need to refill my abiraterone? It was running out. And she said, absolutely, your PSA has gone down. So on the abiraterone, I don't know how much. I wish I had gotten the numbers, but I didn't. But anyway, so my PSA has gone down on the abiraterone after 100+ days. Yeah.
Good news.
Yeah,
we like that. We just want to hear how much, as do you.
Exactly.
Yeah, that's great news, Jake.
Thanks.
Yeah, well, you and Lem both have had great difficulty in getting your PSA results, but yeah, let's find out. Let's find out what the results say, and so next time, be prepared to talk to us.
Yeah, I have a online subscription to LabCorp, but the doctor keeps spelling my name wrong, and LabCorp only finds one spelling, and they ignore all the other ones, even though they're very close and similar, and it's the same patient. So I can't go online to find it. I just wanted to comment for Ken though. I was on bicalutamide for 15 months, Xtandi for 30 months, and I've now been on abiraterone for going on 4 months. And Peter mentioned the mental sharpness thing, and he's definitely right. I'm about as sharp as a dull butter knife on a good day. But it's better than the alternative.
But did something lead you to go from the Xtandi to the abiraterone, or was it vice versa?
Well, yeah, it's the Xtandi worked for 30 months, but then my PSA started going up.
Okay.
So then we had to try something else. All of these drugs, unfortunately, work for a while. Darolutamide worked for 15 months. You might want to talk to your doctor about that. It's a cheap alternative, and it works for Peter. And it worked for me for 15 months, but then PSA started going up, so then it was time to change to another second-line anti-androgen. But I agree that darolutamide might be the best for you right now, especially if you have a bone scan that doesn't show it. Any bone mets, that might be the best choice of all.
Okay, thank you for that info.
Sure.
Yeah, and make a note also to talk to your doc about Provenge, because you're probably eligible for that, Ken, as we mentioned, and we can talk to you more about Provenge next time. But put it on your list.
Okay.
Talk about
Will
with him.
do.
It's complementary. It's not an alternative to any of the other treatments. Okay, Carl Foreman.
Hello.
Hello.
Hi, Carl.
So, yeah, I guess we'll talk about Lynparza well, let's talk about that now. And for Ken Carlson, so I am on Lynparza, also known as olaparib. I had my latest appointment with my oncologist on Friday, in addition to updated blood work. I've been on olaparib since February, so that's about 9 months, and I'm approaching 7+ months of PSA being undetectable. I got some feedback. So that was very good news there. I also had treatments I had my 3-month Lupron shot on Friday, and I also had my Xgeva shot, Xgeva for bone enhancing, because I am metastatic to the pelvic bone. So the Xgeva, which I initially was on at 4-week intervals, then it went to 6-week intervals, and as of Friday, the doctor had said, well, we're going to do it in coordination with when you have your Lupron. So that'll be a 12-week gap, so to speak, with the Xgeva. And we had a pretty good discussion about why he felt I could skip to the 12 weeks. And basically the bottom line is that he says, well, we want to give you some benefit with the side effects of the Xgeva, and he believes that it should, because I've already had these doses in the past, that the bones are without having had any recent scans, but he believes that because of the PSA continuing to be undetectable and everything else that health-wise, that I'm doing very well on the therapies I'm on now. I have to say that I did not recall that the Lupron shot was definitely more painful than the Xgeva shot. The Xgeva shot was put into the upper arm muscle, and it was a relatively small needle. The Lupron shot was a much larger needle and into the butt, and it was pretty painful. And as I'm sitting here now, I still feel it. So it's subsided, but it's I didn't recall that amount of pain from the shot. So I also followed up with I go to a cardiologist every couple of months, because knowing with all the side effects, I gotta make sure I'm on top of my heart health. And he had said everything looked great. And so that's doing well. What he also did say, he said that, oh, isn't your oncologist monitoring your heart? I said, he's not. He's very narrowly focused on the therapies and the side effects, and doesn't really go beyond that into other types of issues, like heart disease potentially, and the side effects that I and everybody else has experienced with these various medications. So it will continue on with the olaparib, which I do take on a daily basis, Lynparza, 400 milligram tablets twice a day. And I was on Zytiga previously, just to talk to Ken Carlson a little bit. I was on Zytiga for just 6 months, unfortunately, before my PSA started going up, and that's right around the time I had genetic testing, and I was shown to be BRCA2 positive. And in turn, I was then pretty soon thereafter put on the olaparib on a exception basis because it's mostly for people on the trial, but because of my BRCA2 diagnosis, I was able to get the medication, which I continue to be on, and thank goodness my medical costs that I have no out of pocket for the olaparib. And just also briefly talking about Provenge, you mentioned that, about the possibility. I also, as Ken Anderson had, I had Provenge back in March and April of this year, also at the recommendation of this forum and specifically with Rick, to the positive effectiveness of it is better to do it sooner than later. And that's why I wanted to have it at that point. I was diagnosed in June of last year, so a year and a half, or a little bit more into my journey. And while the Provenge there's no real indicator to determine how effective it has been. More specifically, it doesn't really affect PSA. But interesting enough, I had an eye doctor's appointment about 2 or 3 weeks after I had the Provenge, and the doctor had said, your eyesight has vastly improved, and I can't explain it. And I said, well, maybe it was the Provenge. We'll never know. But so I've been very much looking at and continue to do research on a regular basis on what the next step would be. Right now, it's kind of nice to be in a somewhat of a holding pattern for the first time in a year and a half, and while things are going well with the medications, and we all know those could eventually change as time goes on. As some of you know, I had been in contact with Professor Bill, a very big loss for myself and for others on this forum. And he and I were on a very similar track. He was also BRCA2 positive. He was on olaparib for 3 years. And so I had hoped to be able to pick his brain further on, but unfortunately that's not to be. Mr. McCoy was on the call last week, which I had missed, and I would listen to the replay. And when I heard the replay, I actually called Rick and said, hey, I heard my name mentioned a couple of times. And so I did contact Mr. McCoy. We spoke briefly. I mean, he's out in California. I'm out on the East Coast. And he had promised to call me back. I had hoped he would be participating tonight, but I'm sure he will get in touch with me going forward, because Rick has told me that he also has a BRCA2 designation as well. So my question to you, Ken Carlson, is that have you had any genetic testing?
My doctor mentioned it today. He said, get the slides from 10 years ago sent. And I talked to him today, and they said have the doctor call and they'll send them out. And I don't know if that's the Foundation one or if that's some other testing that he mentioned. I don't think he was in the context of Lynparza. It was in the context of something, maybe for some context. I'll certainly mention Lynparza. I know my wife did have the genetic testing. She was not, but she's still, some studies have shown that it can be somewhat effective in the non-BRCA state, and so that's what she's doing, for her thing. But and very interesting about the Lynparza.
Yeah, Ken Carlson, one thing we often mention here is that if you're going to do somatic testing, which means testing the actual tumor itself, it's not a great idea with respect to prostate cancer to test old slides. And that's particularly true for foundation medicine because right now you're only entitled to one sequence for whatever cancer you have if you're on Medicare. And so if you use it up on 10-year-old slides, it's not a great idea. You're better off getting more recent, a more recent sample. Now, you can get a liquid biopsy done, which is what Jake did, but the liquid biopsy is not actually covered by Medicare. So the party line is that if you want to get a liquid biopsy done, if you think you would have enough action in your circulating tumor cells to give them enough of a specimen, then speak to the agents, the customer agents at Foundation Medicine, and ask them for some guidance with respect to cost. Okay?
Yeah, I guess my doctor said something like, well, that would be, I don't know what he had in mind, but that would be better than having to get a current biopsy with everything else going on.
Well, you might get away with it, but your PSA is still a little low to reasonably find enough circulating tumor cells to give them a sample, and we found that out before. It really depends on your tumor burden and what's going on, but you can talk. The customer reps at Foundation Medicine are very, very good, so you could talk to them.
And I'll mention him about the old slides, I guess, because things change, or did the slides lose their efficacy?
No, the disease changes.
The disease changes, okay.
So you might run your old slides from 2011 and they may show nothing. That doesn't mean that your disease today has no mutations.
Okay,
now,
I'll certainly.
Having said that, the other discussion is whether you have reason to test your germline, your inherited mutations, and if you have a history of cancer in your family, then maybe that's a good reason. And the germline test is not very expensive.
Okay, well, yeah, I do have a history, not of prostate, but okay, so it's called. I'll look up what germline means and
okay, so germline means inherited, and again, there are some good. There's some good webinar information on our website about it, so you can listen to a couple of webinars, including one by Professor Bill, God rest his soul, who did a great job for us. But you can access that. Your doctor might order it through Ambry. You can access it yourself through Color. It's usually, for somebody like yourself, if you've got any sort of history, it's probably going to be covered by your insurance. Again, we can guide you, but if you want to go just do it yourself, it's going to run you about $200 through color.com, and it's a reliable test.
Okay, yeah, I'm gonna look at it all. I'm taking notes, and we'll be hitting the computers.
All right. Anybody want to say anything to Carl? What caught my attention was the doctor suggesting that you stretch out the Xgeva. But anybody want to comment on that? Okay. No.
As far as Xgeva, Paul also said Xgeva can be, in fact, their protocol at MD Anderson is every 3 months. Monthly. Not monthly. So.
Yeah.
Rick, could I just ask Carl, somehow I missed that. What do you mean by stretch out your Xgeva?
Yes, on Friday was my appointment with the oncologist, and I was due to have my Xgeva shot, which I had last 6 weeks prior, and I was also due for my 3-month Lupron shot. I had both of them on Friday, and we discussed, okay, so when do we have the next treatments? And he said we're going to go to a 90-day for both the Lupron and the Xgeva. And the point he made is that he wanted to give me a little bit of a benefit from the side effects of the Xgeva, because he believes of the Xgeva that I've had so far, I've had several treatments of it, that I should be in a good place with that particular medication, and to go to a 12-week, every 3-month cycle should not be an issue. And I also posed this question to this other forum that I participate in, which is the Online Health Unlocked. And I posed that question, and I got about 50 responses from various people about Xgeva, and it ran all over the place. There was no consistent, whether it's 4 weeks, whether it's every 2 months, every 3 months. It was all over the place.
Yeah, because my oncologist wanted to start me in another month on not Xgeva, but Prolia. It's basically the same drug, only Prolia is half the dose.
Right, and it's only a 6-month drug, I believe.
I think so, yeah. So I guess he was also concerned about side effects. Maybe some of his patients have been popping up with ONJ, osteonecrosis of the jaw, and so now he's getting a little more cautious. So I was fine with that. I'm always in favor of starting out with a low dose, and if it's not doing the job, then step it up.
I think the FDA approval on Xgeva was 6 weeks, 45 days, but I'm not certain about that. But I think that's what it was. But for a long time, I mean, I just have a personal opinion. This is not medical advice, that these bone strengtheners get overdosed because they all have very long half-lives, and we don't need anywhere near as much to do the job as what we're given. So but that's my personal opinion on it. I did get Zometa for a slightly different reason, but I did get Zometa. But if, God forbid, I ever needed it again, I would go on a lesser dose than what's recommended. Okay, Len, any other questions to Carl about the dosing of the Xgeva?
No, that was it, Rick. Thank you, Carl. Glad to hear you're still undetectable after 9 months on olaparib. That's great.
Yeah, thank you.
By the way, I had
Len, I was on and off Prolia all the time. That's the only bone strengthener I ever had, like the 6-month shot, different times, and I tolerated it real well. I did great.
Okay, great, good to know. Thank you.
And when I broke my leg, the doctor said, "Hey, your bones are strong."
Yeah. Yeah, I agree. Rick, I had to turn off my camera because everything was freezing on my screen. I didn't have enough bandwidth.
Everybody's disappointed they can't see you, Lem, but we'll manage. Will we manage, Jake?
I don't know, Rick. I don't know if I can handle not seeing Len.
Okay. Somebody just joined us on the telephone.
Jerry Pelfrey.
Hello, Jerry Pelfrey. I was trying to reach you yesterday.
Yes, we weren't out. We were out and about. Well, yesterday I wasn't out and about. I don't know what happened. I've been out and about today.
Oh, your phone was switched off. Well, I'll call you afterwards and let you know why I was trying to reach you.
Oh, okay.
Did you have anything you wanted to talk about today?
No, tomorrow's my day to get my markers put in at Mayo. So That's
Okay.
all.
Okay. Well, like I think I said to you last time, I didn't even realize they put him in. I thought he was still giving me the lidocaine, and he said, "No, I'm all done." So that's how it affected me.
What?
Okay. So let's move on to Les. Les, what's up?
Okay, a couple things. I signed up for that November 9th Us Two webcast. Do you know if they're going to record it? I lead a small group of advanced prostate cancer guys, and I don't know anything that anybody else does. The only thing that I do is advise them on different things that they could watch either on DVD or some of these webcasts sort of things. I was hoping that they'd be recording it. Do you have any idea? I've tried to see online and I can't figure it out.
Right. I don't know, but you could always drop a line to Terry,
Okay.
and ask her. Terry, Terri.
Yeah,
Terry.
I communicate with her quite a bit.
Okay. So ask Terry. She'll tell you.
Okay.
She's terrific. So
Yes,
we love
she is.
Terry.
I also
So,
have, I'm also signed up for a webinar for Wednesday, I think it is, from PCRI on
right.
advanced prostate cancer treatments. Hopefully that'll tell me something too.
Right.
Okay, next
Yeah.
Wednesday I will be on my way to Mayo for another one of my C11 choline PET scans to try to prepare with what Dr. Kwan would recommend. I got with Len to get some ideas on what the doctor may recommend in case the cancer should be showing up again. Trying to get some thoughts from him, and I may have to make a decision on the spot. And I'd like to have a little bit of pre-information, which Len has helped me with.
Okay.
I'm a little reluctant. My PSA is up to 0.1. It has been less than 0.1. Now it's 0.1, which I assume it's going to start up. I don't know, but my doubling time is 6 weeks once it gets going. It has been all the time in the past, so it goes up rather quickly.
Okay.
So usually, like Len said too, that usually they don't do a PET scan with anything that low, but being a Gleason 10, there's a chance of it PSA not increasing and still have a spread of cancer. So I assume that's why he's doing it.
Well, a couple of things occur to me. I don't know that you would have to make a decision on the spot. You can always tell your doc that you want to think about it, and then give Len a call or us a call or what have you.
The problem is though that we're about 6.5-hour drive up there. If I have to go up there for something, I almost feel like I need to do it on the spot.
Yeah, but I mean, surely you must be able to communicate with Kwon without seeing him face to face. If not, you when you see him face to face, tell him, look, I'm 6.5 hours away. I want to think about it. Can I write you or can I call you?
Yeah.
But do it when you're face to face with him.
Yeah, so the thing is, if they're going to give me a shot or something, I'd almost have to be present. You can't send those over mail.
No, but you can get a Lupron shot if he wants to restart the Lupron. But you just came off your Lupron in July. Yeah. So, as you've heard these guys say, they let it go a little bit. I mean, Len let it go all the way up to, what was it, Len? 4? Did you let it go to 4? And others
It was
have let
2.4, Rick.
2.4. And Peter, how high did you let yours go?
Well, I've had a prostatectomy, so mine went up to 1.
Oh, that's right. You had a prostatectomy. And anybody else who's been on intermittent on the call?
Well, Rick, the first time I was on intermittent, my oncologist let it run up to 10.9.
Oh, that's right. Yeah, I remember. That's right. That's right. So, you know, Les, I think it's important that, you know, there's no real science to this. So, you know, take charge of your own treatment. And if you feel that you want to wait a little more, I suspect that Quan will in any event say, well, let's see how it goes. We've got, you know, let's give it another 90 days. That's just my suspicion. But I think you have time. One thing that might be worth doing is to get a technium scan whilst you're there. Again, for the same reason as we discussed before, because you know, there's a possibility that you could be non-metastatic on the technium scan, but you might show metastasis on the C11. Do you have bone mets right now?
Not right now, no. The only thing I had was those 2 spots on my spine.
Somebody corrected me, thank you. On the technetium scan, so, you know, it's definitely something to talk to Quan about. I don't know that he's going to be too receptive because he's a little rigid, but just tell him that you know that if your PSA is going up and it did go up for a while. I mean, you are castrate resistant, right? Or have you always responded to the?
So far, I've always responded to the ADT.
You have.
Yes.
Okay. Well, then probably it's too early. Then it's too early then to do the technium scan. You need to wait until you stop responding.
Okay.
Len, what's your thoughts? What are your thoughts to share for Les?
Well, I think I've already told him everything in our email correspondence that we had, as Les mentioned. Yeah, are you asking for my opinion, Rick, on scanning at this point when he's only at 0.1? Because I told him I thought that was a waste of time and money, plus exposure to radiation, because it's not likely to show anything when the PSA is. Rick, you probably remember there was a time when Quan wouldn't take you if your PSA was less than 2.0.
Right. I mean, you know, I definitely endorse what Len says. With your PSA now just at 0.1, I don't know that it's worth going all the way up to Mayo for a scan, but.
Yes, well, like I mentioned, I wondered if the reason was because I'm Gleason 10 that sometimes the cancer gets loose without producing a PSA. I was just guessing that was the reason.
But there are other blood measures, Les, that might indicate a type of cancer that doesn't produce PSMA or PSA. You know, the neuroendocrine type, if that's what you're concerned about, you know, that produces, there are other blood markers that they could pick up if you had neuroendocrine.
Okay.
Yeah. Les, this is Peter. My PSA is 0.14 as well. You know, at the risk of injecting levity into a pretty serious conversation, I was thinking maybe for a fundraiser we should have PSA races. We could, we could all track our PSAs alongside each other and see who's going faster and so forth. I'm pretty sure mine's going to start climbing and doubling, and it already did take a significant jump last month. We'll see what it does in a couple of weeks when I do the next test.
You don't want to have that rate because I would win.
Yeah, you probably would. Anyway, yeah, but I have a handicap, or you have a handicap, or one of us does. Anyway, so it's it's an interesting game, but I agree with Len that I think that low scan's not going to show much, because I had a gallium 68 scan a year and a half ago, and I waited until it was 0.8 before I did the scan.
And you're a Gleason 9, correct?
9. Gleason 9, correct.
Yeah. Anybody else want to add anything for Les? Les, I do have one question for you. Have you spoken to Del Jensen since he came back from Alicia Morgan's?
No, I haven't. I did send him an email and asking him for an update. I think it was last Thursday, and he said that he was terribly busy, that he thought he'd have time to write me a note over the weekend, which he did not. He's a busy guy.
Okay.
I did see your note to him, and I assume you haven't heard from him either.
No, I haven't. Okay, not to worry. All right.
Okay,
so
thanks.
moving right along, Len, give the folks your update and anything else you want to say about the benefits of being on darolutamide.
Yeah, first let me add one comment concerning the exchange that Les and I had. I learned that Les had cryotherapy for at least one bone lesion. I don't know how many he had. And it worked, apparently, because he has no bone mets. And I had not heard of cryotherapy for bone lesions. I'd heard of it for tissue, lymph node or soft tissue treatments, but not bone nets. And so then I did a little research, and I found that, yes, indeed, it is used and it is successful for bone lesions. And funny thing is, there's very little reported on this, and almost everyone has bone lesions. If they haven't treated at all, it's with SBRT. Anyway, that was just an aside. So regarding my PSA update, when I first started darolutamide, which was a little over a month ago, about a month and a week, I was at 1.11, and as of last week, it was 0.42. So I'm pretty happy with that. Yes, thank you. And I continue to feel absolutely fine mentally. No change from when I was on drug holiday with regard to cognition, but a substantial change from the way I felt when I was on Zytiga, which, as Peter already talked about, that was pretty rough on my cognition. So, and I imagine, as Jake said, that Xtandi is also difficult with cognition, and possibly even worse than Zytiga. Now, the other issue is physical fatigue. So yes, there is some physical fatigue, but again, not as bad as I experienced on Zytiga. And that just got me to wondering well, how much of the physical fatigue that we feel is compounded by mental fatigue? So if you're free from the mental fatigue, the cognitive issues, maybe you simply feel less tired as a result of the testosterone lowering effects of ADT.
Hey, Lynn,
So
could I
that's
ask
it.
could I ask what your T levels were? How did they
7.
drop? Could I ask what your testosterone level dropped? How much did it
Yeah,
drop?
yeah. It went from 900 to 7.
Ah, that's a big drop. And you're not
That's a
feeling that, yeah. Dang, I wish I
plunge
could get
off a
there.
cliff.
Wish
So
I
no
could get
more bragging about your T levels, huh, Len?
Okay, I had to get that in, Jake. But I'm humbled now by the 7 number.
Well, that means it's working.
Yeah.
Yeah, and you've been back on Lupron LHRH for 2 months, Len?
Yes, about 2 months.
Okay. Okay. Anybody got any other questions for Len?
I just wanted to add a little bit to the conversation that Len mentioned about us. I did have 2 spots on my spine that they hit with the cryo, and for his questions of me is what side effects were. 0. I never noticed anything, didn't feel anything afterwards or since, and nothing in the spine showed up on any scan since then. So I think it did the trick.
I actually do have a comment on this treatment for, well, I was going to say oligometastatic. That might have not actually been the case for Les, but I just want to talk about the treatment for oligometastatic metastases, because as I think many of you know, I'm going to go to Virginia Beach this weekend. And originally Jan Manneride asked me if I would moderate a session on oligometastatic radiation. And I said, I'd be happy to do it. But I said, I have to tell you that my own personal opinion is that it's a management tool, but it's rarely effective. I can't think of too many instances where it's really been good for any period of time. And she said, well, what about Jerry Dean's? Well, yeah, Jerry Dean's got something out of it, but he got 12 months. So, certainly it might help for 12 months, and I certainly support it for that. But it's not something that we've ever seen give durable and continuous remission. And I remember Chuck Ryan saying that to me back around 2010 when I went with a friend at the time to his appointment with Chuck, and they were talking about whether it was worth radiating a couple of spots that he had. And then she sent me the slides that this guy's going to present, and this guy was using the word cure. And I really had a problem with that, because I don't think that people should be walking out of any conference thinking that oligometastatic treatment of oligometastatic lesions can be treated, whether it be with radiation or cryotherapy or anything else, to provide more than a continuing management tool. It ain't going to cure you. And yet it has been a hot topic it was a hot topic at Astro, and it has been a hot topic with the radiation oncologists. And my cynical mind says, well, maybe this is just another way for them to make a few bucks. Now, Len and I went back and looked at Alan Edel's post on the effectiveness, and that Alan sort of agreed with us. But recently, like late September, Alan made another post, and that published a study that seemed to show that, and as I recall, it was a very small study. Maybe Len can bring it up and he can tell you what was in there whilst I'm talking. But it was a very small study that seemed to show that there was more benefit than we had previously thought from oligometastatic treatment. But I think the study was only a few people, like 20, but I'm not certain. Len, can you add anything and fill that out a little better?
I'm just picking, hold on. I'm just picking up the email that I sent you, Rick, about that newer study.
Right.
So hold on just a second. Yeah, it was a clinical trial called Oriole, and it was randomized with an arm for untreated patients. So this is a good study. And let's see. Progression-free survival was 81% for the folks in the SBRT group versus 39%, versus 39% in the control group. And that was only after 6 months, which is a pretty short follow-up period. So there may be, hopefully, they'll be reporting results that are further out than this. But that's a substantial difference there, 81% versus 39% progression-free survival.
So
As a matter of fact, they say the median progression-free survival was not yet reached in the SBRT group.
I never really understand what that means when they say the median is not being reached. What does that mean then?
Yeah, so that means that half of the patients in the study still had not progressed. So at 6 months, there were still less than half of the patients in the SBRT group that had progressed. So in other words, the median may continue to go out further, several more months, or even a year, who knows? Does that make it any clearer?
Yeah, and I think I was wrong. Obviously, it must have been a bigger study. How many? I think it was the 6 months. I knew there was a flaw in it somewhere. Maybe it was the 6 months I was thinking about. So I stand corrected. How many people were in the study?
No, it was a phase 2, so it was a small study. Only 36 men.
Okay.
Treated with SBRT, and 18 in the untreated control group. So it was like a 2-to-1 randomization.
So sorry, there were how many were treated with SBRT?
36, yeah.
And 18 not, yeah. So it's still a pretty small study, but I guess all we want to say is we don't know how long treating these Mets, if you're oligometastatic, what it's going to give you. What I would want to say is I don't think it's curative. I will also say that Jan Mannerite wasn't too happy with my comments, so she removed me as the moderator, and she put in Paul Shellhammer, who thinks that that the oligometastatic radiation was very effective for him, although again, it didn't cure him because he moved on to do bipolar androgen therapy. So I just want to be very leery of that cure word, and I think that basically we're all agreed that it's a management tool rather than a curative tool. And of course, it is effective if you have pain issues. It's a palliative tool. Okay. Thought I'd just get that in. Any questions on that? All right.
I have a question on Len's comment. So here's this drug called darolutamide, and it's been approved in a pretty narrow range of things. And I know if there's something, what avenues do we have to kind of protest or campaign to get wider access to drugs? I know they've done this in the breast cancer arena, where certain drugs were not allowed, and women organized and got the attention of the government or FDA or whatever, and started getting approval for things. Is there any political avenue that we have to get the attention of people to make something more widely available that we think maybe has some use?
Well, Peter, I think and Len can comment on what I'm going to say, but I think the answer is that the way that drug availability is usually occurs in this country is through clinical trials. So I don't know that a drug is ever approved without there being a clinical trial. So the issue is for something like darolutamide, are there clinical trials going on right now in the metastatic castrate-resistant space, and maybe even in the castrate-sensitive spaces? And that's pretty easy to find if you go onto clinicaltrials.gov and you put in the right words, darolutamide and castrate-sensitive, or darolutamide and castrate-resistant, you'll see all the trials that are going on worldwide.
Right.
Now, I don't think we have to petition the drug manufacturers, like, for example, Bayer in the case of darolutamide, to test in that space, because they're plenty motivated, because the bigger the market, the more the drug they can sell. So what is it that you have in mind, or that you've seen in the breast cancer arena, where we could make drugs more available beyond making sure there are clinical trials for them?
Because clinical trials take, there's a certain time frame for them, and it's, so it's prolonged. And I know that you can, if there's enough voices speaking up, sometimes you can push the FDA to move things. If a drug has already been proven to work in one arena, there might be avenues that we could take, writing letters or whatever, to speed up trials or jump a few hurdles to get it approved in other things. If it's been proven, if there's efficacy, that it's not going to kill people.
Right, and we are aware of drugs being speeded up, certainly in the prostate cancer arena, through being given breakthrough status, and what's the other phrase? There's another phrase they use, but Len,
expedited approval.
Yeah, Len, what are your responses to Peter?
Well, I think there are two issues to what Peter is asking. The first is, if you're just interested in availability, that's not an issue at all, because any doctor can approve or can prescribe any drug off-label. So any oncologist can say, I'm going to write you a script for darolutamide, even though you don't fit the strict criteria that were used in the clinical trial for FDA approval. However, the big issue is insurance. Insurance, right? Yeah, they won't cover it. And sometimes they do cover off-label use, but only if you can cite references in the literature that show that it was effective for that alternative condition that you're seeking approval for. Does that make sense?
Yes. Yep. So
Okay.
I guess I'm wondering if we can, if there's room for some kind of political activism here. I mean, so I'm not just looking after myself, but we can, start looking after the wider prostate cancer community. I mean, here you are saying, hey, I'm having success with this drug, and you got it. But there are probably many other men who could have a very positive experience, and yet they can't get it.
Right. Well, I guess you can write to the FDA. You can write to your congressman. But
I will do that. I will begin to do that, and I'll report back. See if I get an answer.
So, Lynn, did you have
whatever happened to that program that President Trump announced? I can't think of the name, the butter knife thing again, but it was about you can try a drug to see if it works. Does anybody remember that?
Yeah, compassionate use.
That's the one. How would that tie into all of this?
No, compassionate use is for folks who are.
No, it wasn't that. It was some other thing where he was here saying that if a drug's available, that you can try it.
That's the right to try. The right to try one, but
thank you, Ken.
Yeah, but I don't think it applies because there are other drugs. Yeah, there are other drugs that are in the same kind of field. My question to Lynn is, did you have any problem switching from one drug to the next? I'm gonna start working now that Lynn's kind of gave it his outline and Peter's kind of given it a push. I'm gonna start, writing letters to both my local girl and Paul and try hard to see if I can figure out some way to get Blue Cross Blue Shield to cover at least me switching. And I don't know how successful it's going to be, but I'm going to try, not this month, but because they've already sent out the next 30 days. But I'm going to give it a try. So, Lynn, did you notice any change when you switched drugs?
Yeah, absolutely. As I mentioned before,
No switching. I mean, no problem switching from one to the next, other than there was beneficial.
So you're asking, did I have a problem getting it approved?
Let me I mean, not necessarily did you have a problem getting it approved, but was there any problem physically in regards to switching from one drug to the next during the, I guess not, going on darolutamide was just a better drug and you felt it right away.
Yes, absolutely.
Okay, that was my question, I guess. So,
yeah.
So I guess, Peter, I'll be happy to work with you writing letters if that's what you want to do, because I'm going to do it anyway.
Great. I'll send you copies of what I get off. I'll send my local congressman some letters.
And it wouldn't hurt if you told your oncologist that you're on Xtandi, right?
Yeah, I'm on Xtandi. On it only like
so just
3.
Tell them that it's crippling your ability to function.
I understand. I understand.
Ham it up.
Yeah, I can do that.
Yeah.
And it is kind of, I've noticed. I mean, I've only been on it 2 weeks, and I must admit I'm handling it fairly well. Anyway, I'll, as you said, ham it up.
The only other thing that may be helpful is that I'm just starting to develop a relationship at Bayer again after we lost our last patient advocate person there a year and a half ago. She went to another company. And we will start to talk about this issue to her, and she may well be calling you, Ken, and you, Len, and you, Peter. So if she does call you to talk to you about the opportunity that I spoke to you yesterday, why don't you bend her ear on this same issue? She's the person that can to work with, to instruct us how to go about creating a patient advocate lobby.
Yep. I have 2 emails sitting to read. I haven't read them yet. One earlier this morning and one later in the afternoon, and I don't know what she had to say, but I will definitely reply to her and see. Bending her ear is probably not a bad idea to see what needs to be done in order for. Honestly, it's all about insurance, though, because honestly, Paul and/or Cortez here locally, I don't think either one of them would have a problem prescribing them off-label. It's just whether or not the insurance will pay for it.
But to come back to what was said before, I mean, Bayer is the one that's going to bring the pressure on the FDA to try and get it approved for either expedited or breakthrough status. And if that happens, it makes it much easier with the insurance companies.
All right, I understand.
Right? And this woman is a doc, and
is that Pooja?
Pooja, Pooja.
All right.
It's her first name. Her last name is Merchant. Okay.
Rick, can I ask a question?
Go ahead.
Somebody mentioned earlier about you can have your doctor can request a 2-month supply of darolutamide.
Right. I did.
Was that Peter?
That was me, yeah.
So how does that work? I mean, can they just ask it for anybody that's even metastatic?
That was the answer I got at the PCRI conference at the Bayer desk. They said that they're willing to give out their 2-month trial of darolutamide to any doctor that requests it for any patient. Okay. Beyond that, you got to deal with the insurance company.
Okay, but it has to be through the doctor.
Yeah, I believe so.
Yeah.
Jay?
I was going to say, didn't you say something about that a couple of weeks ago, Len?
I did, yeah. I didn't go through my doctor. I called that number directly, which is what Bayer wanted us to do, to get in that program. I forget what they called it, buddy program or something. And so I told them I was metastatic, and they said, "Oh no, you're not eligible." So that's when I decided, well, I'll try and go through Dr. O and see what he can do.
Okay.
And it was only after, you had asked me, find out from Dr. O how he managed to get approval for you. And right. That's when he said, the whole technetium-99m issue, that right. I was negative on that scan. Yeah.
Okay. Well, maybe the doctor asking it might be better. So thank you, gentlemen. Appreciate that.
Okay, so Ken, you had a couple of things you wanted to bring up. Have we covered them, or would you still like some time?
You talking to me, Ken Carlson?
Sorry, Ken Anderson.
Oh, okay, sorry.
Of course, I stepped away. No, I think we covered them.
Okay. So
I think we did.
Okay, so if we've covered Ken's issues, we have the last 10 minutes to talk, and it may not be long enough, but it may start us, and then we'll come back to it. But Peter's concern over the ethics of ADT.
Yeah, I think it's being overprescribed. I think it's being prescribed for guys with low and intermediate disease, sometimes going on. Radiation oncologists are using it, because I know it shows up that it has a slight advantage, in certain studies and so forth. But it really wreaks havoc on people's lives. I mean, anybody that's been through it knows that it's a game changer, and it's a gift that keeps on giving. It's just it messes you up considerably on many different levels, and I wonder if it's being overused. It's been around for a long time. It's the go-to thing, and it's starting to bother me that it is so prevalent. And like I had some guys on the call last night who are, they did their research, they did their homework, and they were adamant that they were not going to go on ADT, and they let doctors know and searched around until they found doctors that would work with them and not put them on that for low and intermediate disease treatment. And I think it's a noble cause. And, I just want to mention as an aside here, I think I brought it up before, that in the research I've done over the last several years, within the Department of Health and Human Services in the United States, there's an Office of Women's Health, but there has never been an Office of Men's Health, even though they've tried to institute one, even though the majority of senators are men and the majority of House of Representatives have been men. This has been tried to be instituted, but it's never happened. And I mean, I scratch my head about this stuff. I think there's a lot of room for some activism here, and education, and and really confronting doctors a little bit about the advocacy of just prescribing drugs that might buy you a little bit of time, but the downside can be disastrous and a big game changer, and really screw around with your mental processes, your physical physique, and ability to do anything, to work. It just I'm just really concerned. Yes, I'm concerned about myself because I bought into this, but I'm concerned when I see younger guys and other guys, particularly on the lower intermediate scale, who are being pushed in that direction. So that's. I'll get off my soapbox, but I just wanted to open it up a little bit.
No, Peter, I hear you, but what are the options? I mean, I battled with it when I first got diagnosed, and again, I got my first Lupron shot and it was from my radiation oncologist, which I just trusted the guy 100% when he told me this is what you have to do. But I mean, I can hear you, and for advanced prostate cancer, what do you think the options are? I mean, if there's an option for crying sakes, I want to know about it, because I hate being on ADT. I mean, absolutely hate it, but I don't think there is an option, and I've been on it for almost 3 years now.
Well, this is Jake. Peter's talking about low and intermediate mainly.
Oh, so that's different.
Yeah, people that are high risk like me and other people on here, ADT is probably a lifetime thing. And the other problem is that most of these drugs, these second-line anti-androgens, Zytiga, Xtandi, whatever, they're all tried or they're tested in conjunction with Lupron. I think we only know of one person who's ever tried any of those drugs, right. On a separately, monotherapy. So that might be part of the issue. And obviously, it does have a value initially for people before treatment. It can reduce the size of your prostate. It can reduce the size of tumors before they radiate. But the lifetime deal is for low risk and high intermediate is what Peter's concerned about. And I think he's got a very valid point.
Well, I'm going to take issue here with Peter, a significant issue. I think we have to be really careful how we talk about this subject. I think Jake has brought out a very important distinction, which is that the discussion around the use of hormone therapy for advanced men diagnosed de novo or progressing to advanced disease is a completely separate issue to men who are diagnosed with adjuvant and given adjuvant hormone therapy in conjunction with radiation. And the men that Peter's talking about with low and intermediate are only being given, well, not with low. I mean, I have yet to hear somebody who's undergone radiation with Gleason 6 for Gleason 6 and has been given hormone therapy. I think maybe I can think of one time that happened, and I think that really is unethical. But to give men with 3+4, 4+3, or 4+4 disease, or 4+5 or higher androgen deprivation therapy along with their radiation it's not, as Peter characterized it, a slight difference, it's a huge difference. And the men that I know, especially the men who have 4+3, 4+4 disease, who have not done radiation, have not done hormone therapy, have been much more likely to have their disease recur. Now, men doing intermediate with 3+4 usually only get 3 to 4 months of hormone therapy. And the side effects of 3 to 4 months of hormone therapy are nothing like what Peter characterizes having experienced long-term hormone therapy. And I experienced long-term hormone therapy. I had to do 30 months. And I agree with Peter that those are debilitating. But I don't think that somebody placed on hormone therapy for 3 to 4 months suffers debilitating side effects. Yes, they may after 6 weeks start to have some hot sweats. They may feel a little bit of fatigue, that's less likely. There may be some other side effects, but they only do one shot and then they return back to normal. And what are the benefits? The benefits are that the cancer is substantially weakened and the outcomes show much better progression-free survival. So, you know, I would disagree. And for men who have 4+3 disease, they're looking at 6 to 8 months. They are going to feel a little more. Everybody, you know, we don't give medical advice. I can only speak from my experience and what I've seen. And my experience and what I've seen, I would never discourage a man from doing 8 or 9 months hormone therapy in conjunction with his radiation. In fact, I would encourage it. Based on my, and in my own experience, was it tough doing 30 months? Yeah, it was tough. And I empathize with all of you who are on intermediate or continuous lifelong therapy. I really do, because I know what it felt like. But I do not, I would not discourage it. And I think we've got to be really clear about drawing the differentials and look at the evidence. I mean, Peter, where is your evidence that it only makes a slight difference?
I'd have to pull up all the results again from the tests and stuff, but I don't think it you know, it makes years of difference to someone.
Well, you're not looking at years of difference. You're looking at the likelihood of recurrence, aren't you? That's right. What you're looking at. It's not years. It's how likely is the disease to recur with androgen deprivation therapy versus without it. And the likelihood of recurrence, there is a significant difference. And I will stand, I'm happy to stand publicly corrected if I'm wrong on this.
Okay, well, I'm just opening up the conversation. I just see and hear from guys who are kind of devastated, and their quality of life just sucks. And it goes on for a long time. I mean, I don't know that many, some doctors maybe do prescribe 6 months or 8 months, but some prescribe a year or a year and a half for people. And it's a challenge.
They don't prescribe a year and a half unless the person has 4+4 disease or higher. And
Right,
yes,
now,
if
Rick,
they have 4+4 disease or higher,
I think Peter might be right, Rick. Some of these doctors, I mean, I can only tell you that even my local med onc, she was going to continue chemo after I'd finished the 6 rounds, and I had to put a note to Paul and say, hey, should I have 7 rounds of chemo? And she was going to actually, I know that's different. That's a little bit.
That's a whole different discussion. We're not talking about how much chemo you should get.
No, I understand.
But let's not muddy the issue. We're talking about hormone therapy right now.
It has to do with the doctor's knowledge about the therapies that you're undergoing. And Peter's comment is for those people that are lower intermittent, that aren't advanced prostate cancer patients, that go to a doctor that's not informed, and I don't think there's a damn thing we can do about it, but inform them that we're not doctors, so we can't do that. But Peter's probably right. They probably get too much. I don't disagree.
Right. I don't think Peter's right. I think what these radons do is they look at the protocols, and the protocols are 3 to 4 months if you have 3+4 disease, 6 to 8 months if you have 4+3 disease, and longer where there is a more discretion. Talk to Rich Jackson. If you have 4+4 disease, they'll go anywhere from 12 months to 36 months. I absolutely agree when it comes to 4+4 disease, and we can talk about that, and there are loads and loads of studies. But on the intermediate, on the low, I don't think it's ever prescribed. And I'd ask you to give me instances of where you know that a man with 3+3 disease has been given hormone therapy in conjunction with his radiation. On intermediate, where it is prescribed, 3+4 or 4+3, there's good evidence for it. And it isn't. I don't agree that it's overprescribed. I think that it's correctly prescribed. Do men want to do it? No. Do they hear horror stories? Yes. But I can tell them the horror stories about the men who didn't do enough of it and finished up with recurrent and advanced disease. And then what are they looking at? They're looking at chemotherapy and lifelong androgen and lifelong ADT. Is that better? Versus rolling the dice for 3 to 4 months up front, or possibly 6 to 8 months. Okay, I'll get off my soapbox and let some other people comment on that.
Well, this is Len. I think everybody who's spoken has a valid point. Certainly, I agree with you, Rick, that for the low and intermediate, the short periods of ADT are not going to be long-lasting. They're not going to be harmful, and that they should undergo those short treatments. For the guys with more advanced, the 8s and 9s and 10s, yeah, their ADT certainly does delay recurrence, no question there. The other issue I haven't heard anyone mention is that prolonged ADT tends to drive the cancer to more aggressive, less responsive types of prostate cancer. That's a serious concern for me. If Right. Now that I've restarted ADT, I'm concerned, like, what's going to happen if I continue to respond in the next 6 months or a year? Definitely, I'm thinking the cancer cells are going to be morphing. They're going to try a way around all of the androgen-dependent ways of proliferating. And once they become androgen-independent, then they're extremely difficult to treat. So I wonder if the delayed period of recurrence isn't the advantage there isn't overtaken when you become androgen independent and you become resistant. I have no idea because we've never run trials to figure it all out, but it's a concern of mine.
Well,
which is why I like to do
it. What you'd be looking at is whether a difference between anywhere from 12 months to 36 months of adjuvant androgen deprivation therapy changes the disease for men who have recurrent disease. I don't know if that study has ever been done. It's a very good question. It's worth posing, but I've never heard it suggested that if you do androgen deprivation therapy up front as adjuvant therapy, that it morphs the disease if and when it recurs, Len.
I wonder in my own personal case. I'm a Gleason 8. I had cryotherapy on part of my prostate because the MRI and the bone scan showed no metastases in 2010. I'm wondering if I had been given ADT at that point for a year or 3 months or 6 months or whatever, if it might not have killed the few circulating tumor cells that eventually seeded themselves into my bones so that I now have mets that are incurable. Nobody offered that to me at the time. I'm thinking maybe they should have, and I might be in a lot better shape than I am. Does anybody have any knowledge on that or any opinions on that?
Well, I agree with you, Jake. If you were a Gleason 8, you should have been put on ADT right away. That's kind of what Rick was talking about earlier.
Yeah.
Absolutely. And when I hear of men who are Gleason 8s and are not put on ADT, I go to use Mr. Anderson's phrase, mental. I think it's criminal. And I'm just looking quickly, but I just posted, Peter, here's one study that Mike Scott reported back in 2010 of the benefits of adding ADT to radiation for men with low risk, intermediate risk disease. So, and there are loads and loads and loads of these studies.
Right. Well, there's no answer to this. We're already past the 2-hour mark. I don't want to go on forever in this. We've been using ADT for many, many years now. And this, slowly some different things creeping in, but I'm just, when you think of how many guys are diagnosed with prostate cancer every year, and the number who are surviving and stuff, I just see the toll it takes, and I'm just raising the question. That's all. I don't have the answer to this.
But
just raising the question so that we can begin to think. And I don't know. I mean, doctors are taught things in school. They look at studies and stuff. They go to studies.
Again, you've got to draw the distinction between intermediate disease, where it is used for adjuvant, and advanced, recurrent and advanced disease. There's a huge distinction.
I got that. I got that. I went on ADT myself. I went on right out of the gate. So I know that.
Okay, but the men you talk to on your call don't have recurrent or advanced disease. And I hear them, and yes, they're petrified about going on ADT, but they don't understand, as Len correctly says, that after 3 months or 6 months, it reverses. I mean, I don't know too many people. I can think of one person in all the years who had significant after effects from being on 6 months of ADT when it was given to him for adjuvant. In most cases, it doesn't. Yes, if you're in your 70s or your 80s and they give it to you in conjunction with radiation, it may retard your testosterone coming back. It could be an issue there, but there again, if you look at the guidelines, men over 70 aren't supposed to get treated anyway, which is another red flag. Another red flag to me. I mean, it's of course men over 70 should be treated, but that's not what the USPSTF thinks and a bunch of other people. They write us off once we pass 70. But there are bigger issues using ADT the older you are. Anyway.
Okay. Well, thanks for listening. I'll do some more research on this.
Right.
No, Peter, I think it's a good topic, but I hear Rick as well.
I think it's a very, very good topic. We just have to be careful how we talk about it, and we have to be careful about discouraging men from short-term ADT, because I think that it serves a purpose. Is it pleasant? No. But if you have breast cancer, even with T2 disease, they'll give you chemo, they'll give you radiation, and they'll give you surgery. I mean, fortunately, we tend to think that early chemotherapy as adjuvant therapy doesn't make a difference. There was another study I read just recently that endorsed that. It's not 100% clear, but it's pretty likely that instead of giving adjuvant radiation, if we gave adjuvant chemotherapy, or instead of giving adjuvant hormone therapy, if we gave adjuvant hormone therapy and chemo, or adjuvant chemo, would it help people like myself? Doesn't seem to show that. But thank goodness we're using chemotherapy much earlier for men who have advanced disease today and recurrent disease. 10 years ago, we were using chemotherapy as the last resort. You didn't get chemo until you were basically on your deathbed, and it was palliative. Now they give it to people like Ken Anderson early in the disease cycle. I am certain that's why Dominic, God rest his soul, was around for 10 or 12 years. As certain as one can be without proof that the fact that he was in a trial that gave him early chemotherapy because he had nasty, nasty disease made a big difference to him. And I'm so glad now that these doctors are considering it. Now we've even got that refined, that we give second-line anti-androgens to men who don't have voluminous metastasis, and we give chemotherapy to men who do have voluminous metastasis first, and then follow up with the other one afterwards. Len, did you want to add anything?
No, I think as Ken said, I think this was a good topic. It was a good discussion, and as you said, Rick, it's definitely something that takes more than 10 minutes. We just took about half an hour on it, and it's still a lot left, but I think that's the best we can do tonight. Jake left us. I motion we close the meeting.
We will close the meeting. I'll speak to you guys next week. The first Monday will be the 4th. So we'll be back on the 4th of November next week.
All right, good night.
Good night, everybody.
Good night, everyone.
All right.